Hello, this is Dr. Eugene Meyer speaking, and it's a great pleasure for me to give the first lecture in honor of Dr. Sheng-Po's retirement from the university. Dr. Sheng-Po was a fellow with me back in the 1990s, and I followed his career and participated with him with great interest, and I'm extraordinarily proud of what Dr. Ho has achieved, particularly in the leadership of head and neck surgery in Asia and beyond. So thank you, Dr. Sheng-Po, for the invitation to give the first in your series of lectures in honor of your retirement. I have nothing to disclose except my pleasure in being here and participating in this lecture series. Here's an introduction to the topic of parotid surgery and now and in the future. This, of course, is a caricature, but it's certainly not something you would like to see as your first case, nor would you like to see this real tumor as your first case, a patient with long-standing history of parotid tumor. And here you can see this is something that's become a malignant. Again, you certainly wouldn't want to have this as your first case out of your training. Well, let's talk a little bit about the history of parotid surgery. Even as far back as the early Greek literature, para-auricular swelling was mentioned briefly by the Greeks. Here is something that's also a very interesting coincidence. This was parotid, thought to be a parotid tumor, but in actual fact, it was a metastasis from a cancer of the lower eyelid to the periparotid lymph nodes. And you can see this sculpture from the Vera Cruz back many, many centuries. And here on the right side of the screen, you can see in actual fact a patient who had exactly this problem. At one time, back in the 1700s, it was very dwarfed for very popular objects in art history. And here you can see a dwarf drummer with a trilobe parotid tumor on your left side. Here's again, this is Corporal Scorchicado, a dwarf with a large tumor on the parotid gland. This was a person who was in the uniform of the army of Emperor Joseph Frederick Leopold in the 1600s. And here's again a votive tablet. This is something you can see the surgeon has his hands around a very large advanced parotid tumor, and he's saying, in gratitude for the all-blessed Virgin Mary, Mother of God, is this because I've incised a large growth and cured it. The problem is with these large growths is that, and the poor stage of surgery in that time is that the excision of the tumor was usually followed by excision of the facial nerve, and so that people tended not to want to be happy about having the tumor excised. The concept of surgical excision of a parotid tumor is attributed to the surgeon Dr. Bertrandi in 1802. The initial application of this surgery, again, caused serious disfigurement and disability. If you ever visit Philadelphia, stop in at the Pennsylvania Hospital, and you'll see a large tumor that weighed several pounds that was excised from this patient and preserved to memory of patients who had needed parotid surgery. This is a portrait of several doctors excising a tumor under ether anesthesia at the Massachusetts General Hospital in 1846. It was the first actual surgery done under ether anesthesia. Dr. Billroth, who of course was very famous for doing the first laryngectomies, also described the adenoma of the parotid gland as growing very slowly and painlessly. However, they often recurred after removal and may be inaccessible to the knife, according to Dr. Billroth. So you know that that's a big problem if it was not accessible to Dr. Billroth's very skilled knife. So this should be done with great caution. A physician in Romania, Dr. Condreno, performed the first total parotidectomy using facial nerve dissection and preservation in the year of 1892. And Dr. Nicholas Sen, who we know is a very skilled surgeon in Europe, stated that one should expect that all operations for cancer of the parotid gland will be followed by permanent paralysis of the face. Well, why is that? I mean, today we wouldn't think about that other than to preserve the facial nerve. It's because there was not at that time a good appreciation of the anatomy, of the normal anatomy of the facial nerve as it courses through the parotid gland. Now, Dr. Sistrunk, who we all remember as the surgeon who invented the operation to cure thyroid glossal ducts, was also a surgeon who was interested in parotid surgery. He stated very unequivocally that surgery is the only means of curing parotid tumors. He used an oblique incision made in the skin of the neck and elevated the skin flap, and then did a transverse incision in the direction of facial nerve fibers. Now, this was very important because he was the first one who went in and identified the branch of the facial nerve, peripheral branch, and then dissected retrograde back in order to find the main trunk of the facial nerve and then find the other branches. So he used the lower division of the facial nerve, and he isolated and dissected it proximal to the division of the facial nerve into the upper and lower division. Then he nucleated, once he identified the facial nerve, as you can see in the figure attached to this, that the tumor was enucleated by blunt dissection. And Dr. Sistrunk did 66 consecutive patients in whom these operations were performed. 18% had recurrence within the 5-year study period. 16 out of 60 had temporary paralysis, and only one patient out of the 66 had a permanent partial paralysis, and one had a permanent paralysis. So that's a great improvement over what I had presented in the beginning of this, that all attempts at excision of parotid tumors was accompanied by facial paralysis. And here you can see the incision I mentioned along the skin crease in the neck in order to find the facial nerve. And here you can see the tumor being dissected away from the rest of the parotid gland and then removed. Now, later on in 1934, Dr. James developed a surgical anatomic technique for dissection, and he advocated isolation of the main trunk of the facial nerve in contradistinction to Dr. Sistrunk's operation, which identified a peripheral branch with retrograde dissection. This was what we actually do most often in today's surgery. So the dissection of the facial nerve is identified at the main trunk, and it's carried forward in order that there be less likelihood of injury to the branches of the facial nerve. And here's some interesting quote from Dr. Bailey. In 1938, after accidentally, mind you, coming across the superficial lobe of the parotid gland in the course of an operation and subsequently being inspired by the anatomical studies of Dr. McWhirter, I endeavored to popularize the concept that a parotid gland is a bilobe structure possessed of a large superficial and a small deep lobe connected by an isthmus. I likened this facial nerve to the meat within a parotid sandwich. Very colorful description, but it's important because it points again in the direction of identifying and preserving the facial nerve when doing these operations. And here you can see the sandwich concept that was described a moment ago. Leave it alone. Leave it alone. If you have it out, you'll probably get paralysis of your face. That's what the surgeon said back in those days before it was usually recognized to do the identification first of the facial nerve. In 1945, a medical student, Dr. McCormick, under the direction of the very famous anatomist, Dr. Barry Anson at the University of Chicago, dissected cadavers and described the true bilobed anatomy of the parotid gland and its relationship to the facial nerve in a clear, convincing, and understanding manner. But until 1947 in the UK, all salivary gland tumors underwent surgical enucleation, not excision and removal, and then was treated, for some reasons that I don't understand, with interstitial radium needles. From 1947 onward, surgery was done with the attempt to ensure the removal of the tumor was intact, so the radiation therapy was reserved for recurrence or malignancies. Now, the important turning point, which takes us up to today's operations, was the result of a series of operations at the Mayo Clinic. The Mayo Clinic surgical team uh, had a series of 1,360 primary parotid tumors, and they compared the results of surgical treatment of parotid tumors during 2 consecutive 15-year periods. The first one was pre-war, 1940 to 54, and then in 1955 to 69. Local resection was used in the early series without identifying the facial nerve because it wasn't customary to identify the facial nerve. And then in the second series, there was preservation, identification, and preservation of the facial nerve, and that led to a marked decrease in both the recurrence of facial nerve injury. And so that is in general, the type of surgical experience that we use now. A clinical pathologic study of tumors of the salivary glands was begun at Christie Hospital and Hope Radiation Institute in the UK. At that time, all operable salivary gland tumors were treated by enucleation, as I mentioned earlier, followed by interstitial radium implant, a policy that was developed by Para and Douglas, surgeons in the UK. It should be remembered that at that time, the pathological classification of salivary gland tumors was very confused, and the distinction between benign and malignant epithelial salivary glands was not really clear. However, from 1947 onwards, surgery alone for pleomorphic adenoma was done without the radiation therapy and was done in an attempt to ensure removal of an intact tumor, and providing that this was done, radiation was no longer used. Dr. John Conley, who I studied with, described in 1984 a series of cases and wrote on the capsular significance of parotid tumor surgery, the reality and the myths of lateral lobectomy. As they reviewed their cases of superficial parotidectomies, it became clear that in somewhat more than 60% of the cases of lateral lobectomy or total parotidectomy with preservation of the facial nerve, it incorporated the principle of limited extracapsular dissection at some point in the surgical procedure. In other words, when you're doing your dissection to preserve the facial nerve, you really don't get a comfortable margin of resection deep to the tumor, but there is a sort of a capsule or a pseudocapsule, and it's important to preserve that, and that allows you to remove the tumor in this way with very little possibility of recurrence. Superficial parotidectomy for pleomorphic adenoma of the parotid gland became the standard of care by the middle of the 20th century, following, as I mentioned, the Mayo Clinic report. In 1942, Delarme introduced the concept of a multifocal nature of pleomorphic adenoma. In retrospect, his interpretation was based on artifacts and was probably wrong for most of these tumors. However, this publication helped to persuade many surgeons to do an entire superficial parotidectomy. Now, in 1964, Dr. Eneroth of the Karolinska Institute in Stockholm proved that multifocal pleomorphic adenomas don't exist, but that the tumor extensions do project into salivary gland tissue. Petey and Thackeray in 1957 stated that factors responsible for recurrence of primary mixed tumors after enucleation are two. One is leaving behind peripheral nodules and tumor implantation. The difference between enucleation and local capsular dissection is that the enucleation is a shelling out procedure, such as used by sebaceous cysts or lipomas, while local capsular dissection is a very precise and careful operation in a bloodless field in the plane of the tumor capsule. Superficial parotidectomy, according to Dr. Robert Witt, who's written a wonderful book on this topic, says that superficial parotidectomy is not a true end block resection, but it's actually a partial capsular dissection. And he concluded that major outcomes such as capsular rupture, recurrence, and so forth are from surgical treatment of mobile superficial parotid pleomorphic adenomas and less than 4 centimeters and were not significantly altered by the surgical approach, whether it was total parotidectomy, partial, superficial, or extracapsular dissection. So enucleation, the definition is to shell out like a nut, as in the removal of a tumor from its developing capsule. And there's been a constant battle back and forth between the followers of Dr. Mark McGurk, oral maxillofacial surgeon in the UK, and he, in Manchester between 1947 and 92, there were 475 tumors arising within the superficial portion of the parotid gland, and they were treated by 2 surgical techniques, extracapsular dissection in 380 and superficial parotidectomy in 95. The large series was carried out by Mr. Nicholson and Mr. Gleave, and the contact of the tumor with the facial nerve was recorded in 51% of patients. There was no difference between the treatment groups in the incidence of permanent facial nerve injury. Extracapsular dissection involves dissection in the areolar space that surrounds the tumor, and the decision as far as which technique is to be used was made at the time of surgical exploration after the skin flap was elevated and the tumor identified and studied. Extracapsular dissections is an alternative, perhaps less well-known technique of surgical removals of parotid tumors, which some advocates of superficial parotidectomy characterize as enucleation. The study by McGurk is a milestone in the field and points out that one of the merits of the study is that it relieves the tumor of the responsibility of recurrence and focuses attention, as it should, on surgical technique. It's commonly believed that a local removal of pleomorphic adenoma is followed by a significant recurrence rate, supposedly because of microscopic projections of tumor, and this has been negated by many studies in the meantime subsequent to this observation. And again, we referred to McGurk in 2003 published a very important study indicating that previous studies of extracapsular dissection as an alternative approach to superficial parotidectomy for pleomorphic adenoma was associated with very low recurrence rate and a significantly reduced morbidity. However, in the case when a malignant tumor is inadvertently discovered, this approach by itself may not be appropriate. So in the conclusion then of the current ideas about superficial parotidectomy and the removal of tumors is that before the 20th century, very little was written about parotidectomy. The potential for injury to the facial nerve and tumor recurrence were probably responsible for a so-called handoff approach to parotid tumors. The lack of understanding of the relationship of the parotid gland to the facial nerve held back progress in parotid surgery. Misleading observations regarding the pathology of pleomorphic adenoma, particularly capsular penetration and multicentricity in benign versus malignant, also impeded progress in parotid surgery. The anatomical information from Anson and Patty about the relationship of the parotid gland and the facial nerve set the stage for the popularization of a safe technique from the Mayo Clinic group called superficial parotidectomy, which resulted in a dramatic decrease in facial nerve paralysis and tumor recurrence. The incidence of facial nerve injury, Fry syndrome, and cosmetic defects associated with superficial parotidectomy have led some surgeons to adopt modifications such as partial parotidectomy and extracapsular dissection. The lack of understanding of the difference between enucleation and extracapsular dissection, and the fact that most superficial parotidectomies include a major element of extracapsular dissection, has delayed the transition from superficial parotidectomy and extracapsular dissection for superficial tumors of the parotid gland. The medical legal climate in the United States with respect to facial nerve injuries resulting from the surgery considered the standard of care is likely to delay indefinitely the wide adoption of extracapsular dissection. I estimate personally that I have done approximately 1,500 parotidectomies for various conditions. I applied the principle of extracapsular dissection and partial parotidectomies of the parotid gland, particularly in situations such as excision of deep lobe tumors, tumors of the buccal space, and those extending into the parapharyngeal space, and tumors of minor salivary gland origin. So let's take a little bit of a look at some examples of these benign tumors. It's important when you're evaluating a patient with a tumor of the parotid gland to note that these are usually slow growing, they're painless and mass in the anatomic area of the parotid gland. What I mean by that is not to confuse tumors in the area of the tail of the parotid gland with tumors in the cervical region. There should be no history of facial weakness. Benign tumors do not cause facial weakness. There should be no history of pain for the same reason. And in some cases, particularly in cases of certain tumors of the parotid, there's a history of smoking associated with this. So in physical examination, there's a mass in the anatomical area of the parotid gland. The mass should be mobile. If it's not mobile, but if it's in the area of the parotid gland, you're probably dealing with a deep lobe parotid tumor. There should be no facial weakness because benign tumors do not cause facial weakness, and there may be extension into the parapharyngeal space. Here's a patient with the Warthin's tumor. He was a smoker. There's an association of Warthin's tumors arising in smokers. Imaging can be very important, such as CT and MR scanning. Cylography does not really play a role in the evaluation of these tumors. CT scans are important. Here's a patient who has a CT scan showing a very large exophytic type of tumor. MRIs are also important, and here you can see a patient who has a deep lobe parotid tumor, and you can make a plan for appropriate dissection in that case. Cylography, as I mentioned, not particularly important. This is a patient who has Sjogren's syndrome, and these manifestations of the pooling of dye in the parotid gland gives you the diagnosis for that. We usually don't bother with fine needle aspiration biopsy because we're not going to change the treatment course depending on the nature of the tumor as long as it's benign. Theoretically, the puncture site could weaken the capsule and spill the tumor contents, so it's another good reason for not doing the needle aspiration biopsy. The surgical management of benign tumors of the parotid gland fall into several categories. The most common is the superficial lobe parotidectomy, the facial nerve dissection, or subtotal parotidectomy for deep lobe parotid tumor, and an extended parotid submandibular approach is necessary for deep lobe tumors with parapharyngeal space extension. The goal of treatment in these tumors is local tumor control with minimal morbidity, and preservation of the facial nerve function is the key in that area. Now, Dr. Hayes Martin, who was the chief of surgery at the Memorial Hospital in New York, said a few things about these tumors. One is never assume that a centrally placed parotid tumor is entirely superficial simply because it seems so on palpation. Dr. Martin, of course, had a lot to say about these things before the advent and availability of CT scanning. He also said, proceed first to expose the main trunk of the seventh nerve posteriorly, careful dissection, avoiding if possible rupture of the tumor capsule, spillage of tumor into the wound. If spillage inadvertently occurs, flush the wound at the close of the operation using sterile saline solution, and then put a judicious amount of pressure in the dressing and suction drain in order to prevent accumulation of saliva. This is I included this diagrams of the facial nerve not to terrify you and keep you away from identifying it, but merely to show you that there are many anatomical variations, but by identifying the main trunk of the facial nerve, you don't have to worry about these variations. You just follow them out under direct vision. Well, what about using facial nerve monitoring to guide you in parotid surgery? Personally, I think in not in a previously unoperated case, which is mobile, I think that it's not necessary to do this. Certainly in cases where you're operating for failed treatment of recurrent infection in the gland, where there's a lot of fibrosis and scar tissue and so forth. I think that this is a very helpful to monitor the facial nerve. Pardon me. This is a young man who was referred to me by his primary care physician. He was a student in the music school, one of the fine music schools in our country, and but he had this tumor in his parotid gland, and being a poor student, he had no money and no healthcare insurance. So he came to my office and we discussed this case, and I said, well, you need to have this tumor out and be done with it and get back to your music. And he said, well, I don't have any money, but I'll write a musical piece and name it in your honor. So we proceeded with the surgery. Here you can see we identified landmarks such as the sternocleidomastoid muscle, the greater auricular nerve, and using very gentle but effective um, pressure and retraction, we were able to identify the cartilaginous pointer and the main trunk of the facial nerve. You can see that here with the little pointer. And here again, you can see the main trunk, and here you can see where the main trunk divides into the upper and lower division, and the superficial lobe has been removed. And here you can see been removed in its entirety. I must say that my experience is that most of the tumors of the parotid gland, benign tumors of the parotid gland, are located in the so-called tail of the parotid. And so after a while, I gave up, in most cases, doing a complete superficial parotidectomy and carried out a procedure which included identifying of the main trunk of the facial nerve and the bifurcation. And once the bifurcation was identified, I only dissected free the tissues that were overlying the lower division of the facial nerve, and then removing the tumor. That eliminated any potential danger to the upper division of the facial nerve, which is the one most important in the facial animation. So what about management of the greater auricular nerve? That's sort of controversial. And here you can see the dissection of there's an anterior and posterior division. Usually these preservation of these nerves usually gets in the way of the dissection. And in my own case, I just incised and deleted the greater auricular nerve. Of course, in the preoperative discussion with the patient, I always mentioned to them that the earlobe would be numb, but we had very few, if any, complaints about this postoperatively. So what are the indications for surgery? Well, superficial lobe is used for benign tumors, low-grade malignant tumors, metastatic cancer to the inter and the periparotid lymph nodes from the scalp, and in cases of temporal bone resection. Total parotidectomy we use for high-grade malignant tumors, recurrent mixed tumors, and recurrent and sialadenitis. There's a whole list which you're probably familiar with, I hope, of benign tumors. I'll give you a couple of examples of these. This is a pleomorphic adenoma. This is a nurse who had a large mass in her face. I think it would shake up most patients if they saw a patient taking care of them who had a large neglected tumor like this. This is a patient where you can see she has bilateral parotid masses. You can't take for granted that it's going to be the same tumor in both parotid masses, and in this case, that was the situation. She had a Warthin's tumor on one side and a pleomorphic tumor on the other side. Orthan's tumor, as I mentioned, is associated with cigarette smoking, and these can be unilateral or, in this case, bilateral. Oncocytoma is also something that can be benign or malignant. In this case, malignant, and carried out a more extended excision in his situation. So superficial parotidectomy with facial nerve dissection, subtotal for deep lobe tumor, and extended for parapharyngeal space extension is what's on the menu for approaches in salivary gland tumors. Extracapsular dissection is an alternative approach, as we mentioned by Mr. McGurk. It's associated with low recurrence rates, and reduced morbidity. This is a patient who had a mass, as you can see, in her right parotid gland. It was not mobile on palpation, and the scan showed that this arose in the deep lobe of the parotid gland. At the time of surgery, the superficial lobe of the parotid gland was mobilized and preserved. There's no necessity of taking out the superficial lobe to remove a deep lobe tumor. And then after having exposed the tumor, we went to work in mobilizing the branches of the facial nerve off of the capsule of this tumor and then remove the tumor itself. And what about I had mentioned several times before, the possibility of extension into the parapharyngeal space. Here's a patient who came to the clinic because of the deviated nasal septum, but on a complete and thorough ENT exam, which is what all these patients should have, we discovered a parapharyngeal space mass uh, which had pushed the tonsil over to the opposite side. And here you can see CT scan evidence. This is a extension of a deep lobe parotid tumor. But here again, you can see the tumor making its way from the deep lobe of the parotid gland into the parapharyngeal space through the stylomandibular tunnel. And here's a patient who had a very large tumor of the parapharyngeal space from an extension of a deep lobe parotid tumor. This patient had difficulty in breathing and difficulty in swallowing and difficulty in phonation because of the large mass in the oropharynx. And he snored so hard that his wife made him go sleep in another room so she wouldn't be awakened by his snoring. Here you can see the scan, which shows a mass in the deep lobe of the parotid gland with extension through the stylomandibular tunnel and a very large mass that was causing these symptoms. And you can see the dark area going across. That's an impression made by the stylomandibular ligament. In order to remove this, it required to get into the parapharyngeal space. We extended the usual parotid incision a bit in the neck, undermined the skin, and then dissected out the submandibular gland, which you see retracted anteriorly together with the superficial lobe of the parotid gland. Once the submandibular gland is freed up and still attached by its extension into the oral cavity and by the salivary gland duct. And here you can see the first impression of the mass in the submandibular space. And once we do that, then we can identify the entirety of the deep lobe parotid tumor and use a blunt dissection to remove the branches of the deep lobe tumor from the tumor itself. And then that allows you to use blunt dissection in order to remove the tumor itself, showing here the tumor in the deep lobe on the left and the very big mass in the oropharynx on the right. Well, unfortunately, if you operate, you're bound to get some complications. This includes a hemorrhage, a salivary fistula, facial nerve paralysis, Fry syndrome, and of course recurrence of the tumor. This is a patient who had a superficial parotidectomy and during the few hours post-operatively ended up with a hematoma. You can see here. On further questioning, this patient had been taking aspirins, which I think was the cause of the tumor. Of course, it's more convenient to think that this was caused by the aspirins rather than incomplete hemostasis, but we'll never know. Facial nerve paralysis can be temporary or permanent. This eye shield is very helpful to protect the eye from drying out and being painful. The facial nerve depends on whether the nerve has been cut or removed. And if it's been cut, then the primary anastomosis is suggested, whereas nerve grafting using either the great auricular or the sural nerve in order to get the recurrence of the facial nerve function. And then, of course, using gold weight in the upper eyelid is very important also to protect the eye. And here you can see this should be done under local anesthesia after the operation as healed in order to make sure that you insert just the right amount of gold weight in there to close the eye, not more. The Fry syndrome was attributed to Dr. Lucy Fry, who was a neurologist at the University of Warsaw. And in 1923, she published a paper on the syndrome of auricular temporal sweating. She described a 25-year-old soldier who, 5 months after a gunshot wound to the parotid region, developed facial sweating while eating. This name of the Fry syndrome is attached to what we also call auricular temporal syndrome or gustatory sweating. It's characterized by facial sweating when chewing or during meals, or local facial skin flushing during meals. There's no spontaneous resolution of gustatory sweating even many years later. It's usually in the parotid region or the upper neck, but it also can be seen in other areas of the neck. Dr. Fry postulated there's an aberrant regeneration of the parasympathetic fibers, normally innervating the parotid gland with the fibers of the sweat gland in the skin. And here's a description of this in a figure. And here we can see on the cochlea is the auricular temporal nerve. And here you can see a good picture of the nerve and the parotid. Back in the days before our current management protocol, this is an area that used to be identified through a trans-auricular approach, which they bear the auricular temporal nerve, and by cutting it, you could interfere with the put an end to the parotid sweating. Testing for the Fry syndrome consists of assessing the function of the sweat glands. This is important for topographic information in order to treat the patient properly. The so-called minor test includes painting the area of sweating with powdered with cornstarch, and then putting alcohol on the skin, and then putting cornstarch on top of that. And then the minor test is produced by having the patient using some candy or something which would induce the swelling. So here you can see the brownish appearance of the skin, which is a manifestation of the reduction of the cornstarch by the alcohol. This is a patient that I saw during my fellowship that intrigued me. I saw several patients who had neck dissections who also ended up with the Fry syndrome, as you can see in this patient here. And this is a patient who we did an operation on to replace the skin of the neck with skin from the chest, but somehow or another these very clever fibers regenerated and produced the sweating in the skin flap. The treatment of this is, back in the old days, used to be the use of the scopolamine on the skin, or BAN, which is an antiperspirant. But nowadays what we do is we use the injection of botulinum toxin, and that can eliminate, at least on a temporary basis, the symptoms of the Fry syndrome. And the minor test is done to identify the area of involvement, and then the injection is made in that area. And this is repeated at intervals that depend upon the recurrence of the sweating. And here you see the patient has had a minor test. It's been outlined and then injected with botulinum toxin. And here's another patient who had very profuse sweating. As you can see, he's wearing his Pittsburgh Steelers sweatband in order to keep from having a sweat on his corn cob, but refused any further treatment. And this is another complications. Of course, you can see the multiple nodules under the skin, and this is a patient who had recurrence of the tumor, which had only been biopsied and not removed. Here you can see the facial nerve identified and preserved, and the entire salivary gland removed. The uh, major negative outcomes from surgical treatment of a superficial pleomorphic adenoma are not significantly altered by the surgical approach. Focal capsular exposure is pretty universal, but does not lead to necessarily to any complications. Capsular rupture resulted in a certain degree of recurrence, and there's a treatment program that we've outlined for malignant tumors of the salivary glands. Again, this is different than in the benign tumors because it's generally characterized by an increase in the size of the mass, facial weakness or paralysis, a mass in the neck, pain, or history of facial or scalp cancers. We find the mass in the anatomical area of the parotid gland, pain on palpation, facial weakness or paralysis, a mass in the neck, fixation of the mass to the skin or underlying tissue, and the presence of facial or scalp lesions. This is the distribution of salivary gland cancers, which mostly occur in the parotid gland, but also in the submandibular gland as well. And you can see the incidence of malignant tumors among salivary gland cancers is in the instance of submandibular and minor salivary glands. And here again, we see the same type of distribution. Malignant tumors, the most common malignant tumors are carcinoma X pleomorphic adenoma, malignant mixed tumor, or mucoepidermoid carcinoma. This is a patient who had a long-standing cancer. She was like the first patient we saw. She had a long-standing mass in the area, which had been a pleomorphic adenoma, which over time had increased in size and undergone malignant degeneration into carcinoma X pleomorphic adenoma. We all know the long list of cancers that we could come by, and also the staging system, so I won't go into that. The management of malignant tumors of the parotid gland, again, may be superficial lobe parotidectomy with facial nerve dissection, or total parotidectomy with or without facial nerve dissection, depending on whether the cancer actually infiltrates into the facial nerve, in which case it needs to be excised. Neck dissection is associated with the more common malignancies such as mucoepidermoid, adenoid cystic carcinoma, and pleomorphic adenoma. The key principles of treatment is the extent of surgery is dictated by tumor size and degree of local extension. Facial nerves preserved in all cases and then directly infiltrated with tumor. And if the nerve has to be removed, facial nerve reconstruction should be done at the time of surgery. The N0 neck is treated by selective neck dissection patients with high-grade cancers that I just mentioned. Node-positive neck should be treated by selective or radical neck dissection, and postoperative radiation is given in all cases except for low-grade cancers. The indications for neck dissection include palpable nodes associated with parotid cancer, nodes confirmed as diagnostic or suspicious with imaging, patients with high-grade mucoepidermoid carcinoma, patients presenting with high-grade cancer with facial nerve paralysis, a patient with positive nodes found in level 2 at the time of parotidectomy. Treatment of the N0 neck, as you can see, the patients with treatment of the N0 neck with neck dissection did much better in the patients who had no neck dissection. This is also identifies the same thing in the study by Dr. Stetter. Facial nerve preservation is recognized as a policy of preservation in which residual cancer can be neutralized by postoperative radiation therapy. Surgery for cancer of the parotid gland includes ablative surgery, depends on what's involved as to how much needs to be removed. Neck dissection, I mentioned, should be done in selected cases. And then surgery, reconstructive surgery, again, depends on what you need to do, whether you need to reconstruct the facial nerve or replace skin or whatever. It depends on what happens at the time of surgery. Most of the occult nodes that we see are in the level 2, 3, and 4 of the cervical area. We should depend on frozen section diagnosis and certain salivary gland cancers. The treatment for low-grade cancer is, as I mentioned, surgery and radiation therapy is used for high-grade malignancy, cervical metastasis, or positive surgical margins, which are not otherwise removable. And aggressive histologic findings include perineural invasion, local extraglandular soft tissue, and vascular and lymphatic invasion. The use of adjunctive postoperative radiation therapy is very, very important in high-grade cancers, but should not be used in low-grade cancers, not necessary. So again, this is a few examples. This is a carcinoma ex pleomorphic adenoma. We can see that it's not involved the mandible. A complete total resection of the parotid gland was carried out. The patient did very well, but 2 years later developed metastatic cancer in the lungs and died of the cancer. Patient also developed, you can have malignant mixed tumors involving the palate, which are problematic. Mucoepidermoid carcinoma of the parotid gland. In this patient, as you can see, she has facial paralysis. And at the time of the surgery, which included a neck dissection for positive nodes and also total parotidectomy, is shown at the pointer exactly where the cancer infiltrates into the facial nerve. Adenoid cystic carcinoma is another common high-grade cancer that needs to be treated very aggressively. And actinic cell carcinoma can come in either a high-grade or low-grade manifestation. This one happened to be in the deep lobe of the parotid gland and the required removal of the cancer. This is a patient who was operated elsewhere for cancer of the parotid gland. I was asked to follow the patient in my office, and 2 years later, she came in with recurrent cancer with involvement of the facial nerve. We were able to remove the entire parotid gland and the facial nerve and do a hypoglossal facial anastomosis, which we allowed her to have good facial nerve function. Then squamous cell carcinoma may be confusing because this may occur either primarily from constituents in the parotid gland or metastasis from scalp or facial lesions. And then this poor patient came in with camouflaging a large mass in the parotid gland with a fancy hairdo, as you can see. But once the hair is swept back, you can see the extent of this cancer, which is not resectable. The patient was treated with palliative care. This is another patient who had a widespread cancer, which was reconstructed with a skin graft. This is not advisable, particularly nowadays in the case of the availability of free flaps because of the poor skin and color and texture match. We prefer this type of a reconstruction in a patient who requires excision of skin infiltrated by parotid cancer. And this involves a cervical facial flap and a pectoralis major flap to provide bulk in the area removed. And at the end, this patient looks a lot better than the previous one. So what about survival in the malignant tumors of salivary gland origin? This was done many, many years ago by Dr. Ron Spiro, a surgeon at the Memorial Hospital who unfortunately just passed away. But the importance of this is that this is almost an overlay demonstration that shows you that the survivorship in patients with low-grade cancer, which is stage 1, is about the same. And then the further down you go in high-grade malignant tumors, the worse the survivorship is concerned. And here you can see something that's a little bit misleading. You can see that the second most common cancer identified there is mucoepidermoid, but it shows a good survivorship. This is misleading because most of those tumors would have been low-grade mucoepidermoid cancer, which do have a good outcome, but they're mixed in here with high-grade, which have a very poor outcome. And last but not least, we have metastatic squamous cell carcinoma to parotid lymph nodes. This is a patient who had a cancer of the forehead, was treated by a plastic surgeon. Cancer recurred, but also metastasized, as you can see, to parotid lymph nodes. A radical neck dissection and radical parotidectomy were carried out, including the facial nerve, which was involved. I used branches of the cervical plexus to reconstruct this, and the patient developed very good function of the facial nerve and also very good eye closure. And last but not least, the metastasis to the parotid gland from distant sites. This is a patient who is an anesthesiologist who noticed the mass in the cheek, and upon further examination and excision of this, turned out to be a renal cell carcinoma metastatic to the parotid gland. This was removed together with a adrenalectomy. So as far as the future is concerned, you can see that the incision, the post-auricular incision can be made, the skin flap undermined, and a retractor placed in and a fibroscope used to identify the facial nerve and remove it. And that's where we stand nowadays on surgery of the parotid gland. Here's our department motto. It's called Heal with Steel. It's the emblem of the Pittsburgh Steelers. We're very proud of them and proud of our department for having a good aggressive approach to tumors of the parotid gland. Thank you so much and good luck in your retirement, Dr. Sheng-Po.